I think that nurse practitioners specifically often come to the job with experience in handling some of the challenges that face the nurses, which allows us to relate and empathize with them. This improves our relationship with the nursing staff and makes it maybe a little bit easier for them to come to us with their concerns. This experience also allows us to facilitate communication between the nursing and the medical staff. And quite honestly, I feel like when I'm taking care of these patients and we're discussing the plans for the patients, I feel like I'm able to identify where those gaps may be.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your host, Dr. Cyrus Askin, here with my co-host, Dr. Nick Mark. Nick, how are you doing?
I'm doing good, man. Good to see you, buddy. Getting excited for our upcoming visit to Chest.
Yeah, that's
It'll
right.
be fun to hang out face to face again, meet some of our fans. Yeah, good stuff.
It will be. The funny thing is, when our listeners actually and viewers actually get to experience this, it's likely to be after Chest has occurred.
That's right.
But
the mystery of time travel.
The mystery of time travel. That's right. Well, here we are. We're recording on the 30th of August, and so we're looking ahead to Chest today. We're also looking ahead to what I think should be a really great topic. What do you think, Nick?
Yeah, totally. So why don't you tell our listeners, what are we going to be talking about today?
Oh, fantastic question. It's almost like I set you up for that. Last season, we got some really great feedback indicating some interest in exploring the roles of PAs and NPs in the world of critical care. And so, as Nick always says, we love feedback. We listen to your feedback. We crave feedback. And so we're really excited to actually explore this topic in detail today. And actually, what's even better is that one of our listeners reached out and specifically was like, you know what, I heard you guys were maybe interested in exploring this topic of advanced practice providers in the ICU or those that work with the critically ill. And that listener happens to be our guest today. And that's going to be...
He volunteered as tribute.
That's right. He did volunteer as tribute. That's going to be Gary Macy.
So Gary is a critical care nurse practitioner at the Neuroscience Intensive Care Unit at Duke University, where he's worked since 2001. He's got a ton of experience to share and a great perspective on APPs in the intensive care unit that we look forward to exploring together. Gary, welcome to Critical Care Time. We're so excited to talk to you. Why don't you take a minute to introduce yourself, tell us about yourself. As I like to ask people, give us your superhero origin story. What made you go down this path?
Sure. Well, first off, I just want to say thank you very much for having me. It's my pleasure to be here. So my story started when I was actually sitting in physical assessment class during my first or second semester of nursing school at West Virginia University. I was feeling totally stoked at the time that I'd actually made it into the program. And we were introduced to this faculty member named Mona Counts. When we were told she was a nurse practitioner, I remember having no idea what that meant. Well, she proceeded to tell us a bit about who she was, what her training was like, and what she did. I was amazed because she sounded just like a doctor. She explained that the NP role was nursing's answer to the shortage of doctors in primary care, which left a lot of people without access to health care. She also told us that medicine's answer to the same problem was the physician assistant. Well, my mind totally exploded, and from this moment forward, I knew I wanted to go on to NP school to be a nurse practitioner.
That makes a lot of sense. I think a lot of us are kind of inspired by the people we meet along the way during our training, and it's pretty cool to hear that you sort of came upon this very organically and also early in your nursing career. One question I kind of have is, so before we get into life as a nurse practitioner, can you tell me a little bit about what life was like in bedside nursing and like kind of some experiences maybe you had, that sort of thing?
Sure. Well, following graduation at WVU, it was I graduated in 1996. I then got a job at West Virginia University in the surgical and medical intensive care unit. I was cross-trained for both, and I knew that if I wanted to go on the NP school at the time, there was a requirement that nurses worked for at least 1 or 2 years before they went into NP school. So I worked at WVU for a year, and then I ended up moving back home to South Jersey and worked at Hahnemann University Hospital for a year in their surgical and trauma intensive care unit as well. And I did that right up until the point when I attended NP school at Duke.
Wow. Okay. So tons of dynamic experience, and so just so that I help me understand. So, how much time did you spend bedside nursing before you started NP school?
2 years.
Okay. Cool. Wow. So yeah, 2 years, and it sounds like you were able to also work in a bunch of different environments, which I would imagine was probably helpful.
Yes, it was. It was an incredible experience.
Mhm.
Coming out of school, working in the intensive care unit, while I had some rotations there during nursing school, and obviously that is where my heart drove me to work. Um, it was fabulous. This was back in '96 through '98. We were using Swan Ganz catheters. We were using I just these were critically ill patients, and just a wonderful experience.
Amazing. Amazing.
I remember a similar experience in med school where seeing the ICU and being like, oh wow, this is like where people actually use that physiology we talked about. Like,
Yeah.
it was very, very interesting, sort of final common pathway for caring for sick people and, diverse diseases, but one place for all of them.
Yeah. And it was really in the ICU setting as a nurse where I felt like there was an opportunity for me to maybe work as a nurse practitioner and provide a steady presence in the unit.
Makes sense. Makes good sense. So I know that we want to get into the meat and potatoes of this episode in just a little while, but I think this is kind of a nice little segue. So I'll just ask you straight up, Gary. So you wanted to be a primary clinician. You wanted to be an ICU clinician. Why not just go to medical school?
Yeah. Well, I can tell you, first off, I wasn't even thinking about medical school when I went to college. I was focused on getting a degree that would get me a job, make decent money, and lead to a happy life. In fact, I wasn't even thinking of NP school at the time because I didn't know what NPs were. So I followed in my mother's footsteps and I went into nursing. And if you don't happen to know this, nursing is a pretty terrible degree if you think you want to go to medical school later. Uh, it would have taken me at least another year or two of completing the prerequisite courses. And, that just was not something I wanted to pursue at the time. It's not like you can graduate nursing school one day and sit for the MCAT the next. It just doesn't happen. But it does. But a career in nursing or a nursing degree just happens to be the perfect degree and the only degree for getting into an NP program. Plus, I could be done NP school in honestly half the time at half the cost and have half the amount of debt compared to what I would have collected during medical school. And I feel like I would have had a better work-life balance. So for me, it was just a natural progression of my career to go into NP program.
Makes sense. And I'll just point out for the listeners that half the debt when you graduate probably means a quarter of the debt by the time you pay it back, if not less. It's a big difference. So maybe we should get into some terminology here. So there's a lot of terms that get floated around: APP, physician extender, mid-level, provider, clinician. What is the nomenclature that we should be using here?
Sure. Well, I will say that I am guilty of using all of these terms at one point or another, but I don't think it's right, and I don't think they really explain what an NP or PA does. So we can take a look at some of these one at a time. APP or Advanced Practice Provider, I don't know what is the reference point. If I'm advanced, who
Compared
or
to
what?
who?
Yeah, who or what am I advanced relative to? Am I more advanced than a doctor? Then you've got physician extender. Well, what part of the physician am I extending? That's kind of
Don't
silly.
answer
That
that.
doesn't make sense. Exactly. Mid-level provider, again, relative to what standard? Did I just go from being more advanced than a doctor to somewhere halfway at the level of a doctor? I'm not sure. Provider, just plain provider. This might actually be my least favorite of all. I have no idea what this means. I thought I provided for my family, but I'm not doing the same stuff for patients. Everyone working in the hospital is a provider in one way or another. And when a nurse tells me that a family member wants to speak to a provider, I secretly say to myself, I bet they didn't.
They did
And
not
then,
Yeah.
say that. You're right.
Yeah.
and then, clinician, again, so is every other person working in a hospital. So to me, here's what I am. I'm a nurse practitioner. My NP degree says I'm a nurse practitioner in critical care. I renew my nurse practitioner license with the state boards of nursing and medicine. As far as I'm concerned, we should just leave it at nurse practitioner or physician assistant. As time passes, I think the public is smart enough to learn what being an NP or PA means, but it will never happen if we continue to keep changing the message.
Love it. So keep it simple. Use descriptive nomenclature about your degree. Don't use some vague term like, clinician, provider, mid-level, extender, APP. Yeah, great.
That makes perfect sense to me. And I think I actually really like, Gary, the way that you approach that. And it's like, just don't make it so complicated. Just call a spade and be done with it.
Yeah.
which I love that. So I'm going to throw another kind of curveball into the works and say, okay, well, your degree, you said what your degree stated, but I'm, the degree, I guess, in its full title is it's a doctorate degree. And so I believe it's a doctorate of I don't know what the actual nomenclature
DNP.
is. DNP,
Yeah,
right?
doctor of nursing practice. And that's
yes.
completely fine that you have no idea what that means.
Because I was like, I think I was going to say it's a doctorate of nurse practice. That doesn't make sense. So doctor of nursing practice. Okay.
Yes.
So, well then, I've heard from other folks in the community, like, I have a doctorate. So I have a doctorate. I'm doing patient care. Why not just call me a doctor? I mean, I can do all the same things that the quote unquote doctor can do. So, how do you react to that, Gary?
Well, I am not someone who calls myself doctor. I don't refer to myself as a doctor. I don't know why anyone other than a MD or DO would call themselves a doctor. First of all, there's nothing more confusing in my environment of working in the ICU. There's nothing more confusing to a delirious ICU patient than a person who introduces themselves as a doctor nurse. It's very misleading. Every other doctor and NP in the room thinks it's misleading. And it really just tells me more about what makes you tick. And it's not good. So as an NP who has a DNP myself, I'm perfectly happy with telling people that I am Gary, I'm a nurse practitioner, and I'll be helping taking care of you today. However, I will say this, if an NP has a doctoral degree and they're teaching somewhere and they want to be called a doctor by their students, then have at it. But this should, as far as I'm concerned, should not happen in the hospital.
Yeah. Makes good sense. I was just going to say, Nick, and that makes good sense to me. And I'm glad you added that caveat, because it's like, if you're a, professor of whatever, psychology or something, and you're teaching in a university, often they're referred to as doctor. They have a doctorate. But then
Dr. Jill Biden, if you're listening to this podcast, we're cool with that.
Yeah, we're good with that.
Growing up in South Jersey, Dr. J.
Yeah,
right.
Exactly. Yeah. Right. But I would I'd be a little nervous if Dr. J was at the bedside referring to himself as a doctor,
Right. That's right.
Or Dr. Dre for that matter.
Or Dr. Dre. Yeah.
Yes. Or any of those doctors. But yes. Yeah, I think that's a great approach. I think my takeaway from that is, yes, you have a doctorate. That title is certainly appropriate in certain settings, but when it comes to the hospital setting, it can be very, very confusing to patients, to family members, to use that term, given that, you're a nurse practitioner and frankly, you own it, Gary, which I think is like great.
Yeah. Dr. Pepper is Mr. Pepper in the hospital. Yeah.
That's right.
All right. So
everybody knows it's not a real doctor. I mean, you can't consult that.
That's right. It's an inferior soda as well.
Oh no.
Got to edit that part out. Okay, Gary. So informed by your experience and decades of work in this space, what is the best role for a nurse practitioner in the critical care setting?
Sure. Well, I think that the best role for an NP or PA is one where they have the opportunity to achieve and exceed their professional goals. They're respected and trusted by their peers, leaders, and administrators as a valuable member of the team, where they feel like their voice is heard and they are properly paid. Additionally, it is important to provide a role that offers upward mobility and provides support. What I have said at times during my own career to the people who I work with is that our unit should allow me to be excellent. If it doesn't, then we need to get some work done on this, because it can lead to job dissatisfaction, a lack of engagement in your career, and feelings of being disrespected and underappreciated. And all of this could eventually lead to burnout, quitting, and being fired. So, in my mind, there are many roles that can fulfill this objective, and there's not any one role that NPs in the ICU setting need to be confined to.
Yeah, and I'll just say that from my own experience in training and in my current practice, I work with several NPs and PAs who are part of my team. Like in the ICU, we work collaboratively together. We have a full census to sort of divide the list up. And then in another context, when taking care of patients who are post-surgical, whether it's neurosurgical or post-cardiac surgery, the mostly PAs who take care of patients in the post-operative setting are huge help, right? I mean, the surgeons would not be able to be in three places at once, but by having a team, they're able to take great care of everybody inside the OR and outside. And it's kind of hard, honestly, to imagine how the health system where I work would work if not for these people.
Yeah, I think we're all working together towards one common goal.
And I think we're going to get to this in just a moment. But as I hear you speak, Gary and Nick, your experience is very similar to mine. I think that there are scenarios where, especially in critical access environments, where there's just not enough of us in general to go around. Us being physicians, PAs, NPs. I think you would be somewhat narrow-minded to not support kind of an expanded role for our PAs and NPs in those situations, kind of a more independent role, that sort of thing. Because the alternative is nothing. The alternative is I think worse for patients. But in general, in the places that I've practiced, I think that model of like a team approach to care, where we have our roles, we have our responsibilities, we divvy up the work, but then we also kind of bring our perspective to the table. That has been time and time again probably like my favorite practice environment to work in, because I find like you with your years of bedside nursing experience, or someone else with their years of maybe bedside nursing experience, does bring a unique perspective that enriches the team. And I think if we remember, I say this not infrequently, that medicine really is a team sport. We all bring our unique skill set to the field. And can work, I think, really, really effectively in harmony when we don't focus so much on the letters after our name or the title before the name, but like, what are you going to do for the patient? That's what really matters, right?
That's right. That's exactly right.
So, not I don't want to push this, kick this can down the road anymore, but getting to that idea of nurse practitioners or physician assistants potentially being able to practice kind of independently or unsupervised. Specifically, let's focus on like an inpatient setting. What what are your thoughts on that? I mean, where do you fall on that question?
Are you referring to nurse practitioners or PAs having the ability to practice on their own?
Exactly right. And
Without
I say that
Independent, unsupervised, full practice authority. Yeah.
and I say that only because I say that only because like the only with a few exceptions, with like small community facilities that barely even have like real what we would call ICUs. What I'm really only familiar with the model that I described before, where it's sort of like you have a physician that's kind of like more or less overseeing the entire unit. And then you might have one or two nurse practitioners or PAs that are part of the team, and they're obviously very important to the team, but you still have this quote unquote physician oversight. That's what I'm
Yeah,
familiar with. So I'm almost coming at this from a perspective of naivety, and I want to learn. So teach me.
sure. So in the state of North Carolina, nurse practitioners cannot be granted full practice authority. So this is not something that I have firsthand experience with either, but I am aware of the movement and I do have an opinion on it. I know this topic has caused some friction and bitter disagreements between NPs and physicians, but whether you think this is a good idea or not, it's already happening. There are currently, I believe, 27 states in the U.S. that provide full practice authority for NPs. And the number actually spiked, I believe, during the COVID pandemic when waivers were issued by executive, legislative, and boards of nursing orders. Those who are in favor of this report that the benefits include improved access to healthcare, just like NPs were originally arguing back in the 60s. It also helps provide care to those in the underserved areas. It's a more streamlined and efficient healthcare model that is less expensive, all while protecting the patient's right to decide who cares for them. Following the COVID pandemic, there were studies that have been published that demonstrate an increase in the use or access to healthcare, improved patient satisfaction, as well as decreased utilization of the emergency department. So, for what it's worth, for what my opinion's worth, I'm actually all in favor of NPs receiving full practice authority. At its foundation, my stance on this reflects a fundamental value that I hold close to my chest, and that is, as I described earlier, let these people be excellent. I don't know if it will transfer to the inpatient or critical care setting, as you had mentioned. So I think we'll just have to wait and see what happens as more information is available. Ultimately, I think this is going to be decided by the public's demand for access to high quality care and NP's ability to provide that care.
Yeah, I think that's a good summary of kind of where we are, that like we're at this sort of transition point where independent practice authority exists in roughly half the states. And so there's sort of this natural experiment where we can see that, by making things like primary care more available, it improves access to care, reduces waits, reduces ED utilization. So there's definitely some good things there. Let's drill down though and talk about in the critical care setting. So what's the most effective model that you've seen as it relates to physicians and NPs or PAs working together within the same system on the same service?
Yeah. So, in terms of the models that I have seen, I would say that the one that supports the most collaboration between the physicians and the NP or PAs are the best. This is the model we've had for around 25 years in our ICU. In our ICU, the attending is the team leader, and an NP or PA works very closely beside them, performing neurologic exams, going through rounds where they review the events from overnight, formulating a plan for the day, and later following up on the plan. The NPs and PAs provide 24-hour coverage 7 days a week, 365 days a year. During the night in our unit, it is normal to find only APPs covering the unit. So we handle all new admissions and post-ops. We perform procedures such as central lines, art lines, LPs. When swans were popular, we were putting swans in patients all the time. If there's a consultant to call or a family member to talk to, we also take care of that as well. There is also a other model where the unit is divided up somewhat arbitrarily into a teaching and a non-teaching side, where maybe the non-teaching side is an APP and an attending, and they just kind of zip through rounds and get all the work done and kind of get their day started. And then the other teaching side might be where it's led by a fellow and a resident, and there's also no attending on that side. And then admissions may be, divided up one way or another, depending on what the needs are for the learners.
And I'll just react to that and just say that I kind of hate that model whenever I encounter it. There's a couple of things that just kind of irk me. One is this idea that, there's like an efficient side and there's like the inefficient side. And it's like, no, like both sides should be efficient. Like we owe that to our patients, right?
Yeah.
Cyrus and I have a whole episode about this, like how to round.
And everybody should be learning and everybody should be teaching.
Exactly. Like the idea that learning only happens on the left side of the ICU, but not the right is crazy to me. It also creates this idea that there are like, quote, interesting patients and quote, uninteresting patients. And I hate that as well. Every patient has something to teach us if we're there to learn.
That's right.
Nick, I totally agree. And I think, the model that I keep thinking back to, I've kind of alluded to already, is similar to what you were outlining, Gary. It's like we had one or two nurse practitioners in the neurosurgical ICU that or the I guess it was the neuroscience ICU as well, because we had neurosurgery and non-surgical patients. But we had like one or two nurse practitioners that were there. There was an attending, and then me as the fellow, and I think we might have had another fellow here or there too. Um, and what I found is like the nurse practitioners were really, they were the institutional knowledge. They were the rock for the team because they knew the medicine. They may not have as much experience with, unusual cases or nuanced cases as the attending did, but by and large, they knew how to get the work of the day done. They knew what to look for. But what was even more valuable is like it's the pattern recognition that's been drilled over and over again because they're present consistently, and it's the understanding of the hospital too. And so I feel like when you have attendings that are, rotating between administrative, academic, inpatient, outpatient, all of those different responsibilities, but then you have a nurse practitioner that's like, yeah, I'm here week on, week off until the end of time. Obviously, there's going to be value inherent to that. And so I found myself not only befriending these nurse practitioners who are still like some of my really good friends today, because we, spent a lot of time together, but I found myself relying on them because they had such deeply ingrained knowledge in the system that I just couldn't bring. And they teach me about like neurocritical care. And it was like, oh man, yeah, I really don't know a lot and they know a lot. And so please teach me, help me learn. It was a really great, I'm never going to forget that rotation.
Yeah, the ones on my team are very similar, like sort of rock to depend on, and also like really up on the facts. Like I'll be like,
Yeah.
I think the blood pressure goes this, and they're like, no, guidelines changed like 3 days ago, and now it's this.
Yeah, it's awesome.
Yeah.
I love that. So yeah, all of that like really resonates with me. Now, kind of getting back to that, what does the nurse practitioner or the PA actually bring to the table? So I think probably I'll focus more on the nurse practitioner specifically, because the way that I would look at it is like, well, especially someone who's had a robust bedside experience, like that's legit. That's important. There's a lot that can be gleaned from that. So Gary, what are your thoughts on like what unique perspectives can the registered nurse version of Gary bring to the last 20 years of Gary and bring to the team, and most importantly, bring to the patient?
First off, I agree with you. The institutional knowledge is huge. At the same time, nursing school for me was a long time ago, and while the 2 years seemed a lot at the time, it's really just a fleeting moment when you look at my entire career. But I will tell you that there are some things that I have not forgotten, that I still remember, that I think I am able to use to my advantage even today. So, I think that nurse practitioners specifically often come to the job with experience in handling some of the challenges that face the nurses, which allows us to relate and empathize with them. This improves our relationship with the nursing staff and makes it maybe a little bit easier for them to come to us with their concerns. This experience also allows us to facilitate communication between the nursing and the medical staff. And quite honestly, I feel like when I'm taking care of these patients and we're discussing the plans for the patients, I feel like I'm able to identify where those gaps may be. If this plan's not going to work, where specifically is it not going to work? And I'm able to kind of look at things from that perspective. If that answers the question, I would also say that APPs in general, not just NPs, but we're a constant presence in the unit. We're able to provide a high level of care on a consistent basis and maintain that continuity of care that you might not get otherwise. APPs are familiar with the differences between the care of different attendings, and they can adapt to provide that care accordingly. I mean, there are times we have, I don't know, 9 or 10 attendings, and, I'm getting pretty good about taking care of patients the way Cyrus would take care of the patients. So when you come in the next morning, things are going to be more along the lines of your care. And at the same time, when Mark's on tomorrow, I can take care of, things his way.
But at the same time, I bet you there's some element of reducing non-rational variation between Cyrus and Nick care, like the things that like one of us is doing that just make no sense. Hopefully those get smoothed out a little bit.
They do.
And some of the things where it's like, one person consistently keeps Foley's in too long, you could be a voice to be like, why don't we get that out today?
That's right. That's exactly right. My perspective on all of this after working for 23 years in the neuro ICU is there's so many right ways of doing things. I tell all new people, all new learners, NPs, fellows who are anyone who's getting frustrated because they feel like every time they do something, it's wrong, but last week it was right. There's 3 to 4 right ways of doing things, and there's 2 to 3 ways of, bad ways of doing things. Just don't pick one of the 2 to 3 bad ways. Pick one of the 4 ways. If you're right, I'll talk to you about it. We'll go over it and not worry about it. I mean, you guys know, you've seen it yourselves. You've got experts with different opinions on everything. Well, if everybody's an expert, how can we not agree on what the proper ICP is? Should we keep the ICP less than 20? Should we keep it less than 25? Or do we just agree that we can agree and we're going to pick 22? And now all of a sudden the TBI guidelines are less than 22. And I'm thinking, well, last week it was 20, so I think this is one of the areas where, having been in a place for as long as I have been, as well as many other NPs in our unit who have a lot of experience, is that I think we're able to provide that smooth transition, taking out the bumps, some of the disagreements, and just kind of helping everybody realize that, hey, you're doing the right thing here, just maybe a little bit different. And I think in that way, APPs can help promote the culture and maintain the norms of the unit. And we can be helpful in terms of education, not only just other NPs, but residents, attendings, even. It's nice to teach them something every once in a while, and teaching the fellows. Honestly, we're all just teaching everybody. And we're there to help them with policies and procedures, which is another, issue for the new learners. And at Duke, we have, it's kind of a joke, we have what we call Dukewees. I don't know if you that.
Oh, that's
and we are like the owner of the Dukewees.
That's
nice.
Yeah, I can imagine that.
The
that's
guardians, I guess.
That can be cumbersome for new folks on the the things I really take away from that is definitely like, from my own experience, I learned a ton from the nurse practitioners that I rotated with, and I really appreciated that. I was a trainee, I was a learner, and they rose to the occasion, and they made me look smart. They made me feel like I was, doing right by the patient. And those are very foundational memories for me as a young fellow. And then the other thing I think is just, you mentioned this early in your answer, but like the logistics of our plans. At the end of the day, the bedside nurses are the ones that have to execute our plans on the inpatient side. And so, like, if I come up with a plan that sounds great to me, it may be completely impractical in terms of like the actual implementation. I feel like that's where someone like yourself can be like, that sounds great, doc, but here's the thing, that's never going to work. And these are the reasons why. And then you can kind of level with the bedside nurse to smooth that whole interaction over and come up with a more practical approach.
Yeah, that's exactly right. That can even be broken down into something as simple as, we're pretty focused on bowel movements in our unit.
Yeah.
And there will be
there's also called Dukewees.
You may have somebody who's not been in the unit for a while. They'll say, okay, well, let's order a Dulcolax suppository PRN. Well, I can tell you that suppository is never going to be given, because nurses do not want to be cleaning up
per whose need,
right? Right, or it's going to be given at like 6:59 p.m. or 6:59 a.m.
Heck yeah.
And so I know that because that's what I did, and so it's like, no, 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 you're going to have to schedule it. You're going to have to tell them you want it now, type of situation. So,
That's great.
that's a silly example, but it's one that often comes up, and we joke about it. But I think it's a good example of identifying kind of, the real implication of these plans and how they're gonna go down.
Makes sense.
Love
Yeah,
it. Yeah, makes sense.
yeah, I think those are some great points. I wanna talk a little bit about NP and PA education, because I think what a lot of people are maybe confused by or uncomfortable with is kind of the variation that exists here, right? Like if you contrast, like, my experience, which is like doing a residency and then a fellowship, and then being, quote unquote, a board certified intensivist. Actually, not quote unquote, I am, versus somebody who graduates and then has, a decade or two of experience doing it. There isn't necessarily like a document that codifies that experience doing critical care. How do you sort of, what are your thoughts broadly on this question of NP versus PA education?
Well, let me comment first about your, mentioning about there not being a document, and I agree with you 100%. There is not, other than my doctoral degree, which really isn't necessarily a reflection of my clinical skills in the ICU. There is nothing that separates me from the NP who just started last week.
Right.
I'm not a doctor, and you guys can tell me differently, but I've seen doctors who hold ranks of instructor, associate clinician, assistant professor, and professor. All of these are kind of like promotions, I would say, within your profession. But I'm Gary Macy, the NP, and that's it. And the next person who graduated last year and started last week, they are an NP just like me. And so that is something that really has kind of bothered me during my career. I've not been able to come up, obviously, with a great solution for that, but I definitely understand where you're coming from, and it is a a point of concern for myself as well. Now, when you get into comparing the programs or the education between an NP or a PA, I think that there are more similarities than differences, and both turn out excellent graduates. That being said, there are a few differences between them. The most obvious difference is that you have to have an undergraduate degree in nursing before you can enter NP school. And as I mentioned earlier, in the past, it was almost mandatory that you would work for a year or two before applying to NP school, but this is no longer the case. You also need you also need an undergraduate degree to go into PA school, and this is often in a science such as biology or chemistry, but does not have to be. For example, one of my friends and PA coworkers got a degree in zoology, and I also know of a nurse who went to PA school rather than going to NP school. Both programs take about 2 to 3 years to complete, and both have a didactic and clinical component. NP programs allow students to select a pathway that focuses on a particular patient population such as women's health, acute care, gerontology, nurse practitioner, among others. PEA programs typically require about 1,000 hours of clinical time, whereas NP programs only require 500 hours. Despite that, many of the NP programs, you will have more than 500 hours of clinical time by the time you graduate, but that is the minimum. In our unit, we hire both NPs and PAs. Both have the same scope of practice. Both are paid the same, and both are excellent providers.
Yeah, I think that there's this sort of question of like, how do you evaluate somebody's experience? And I think the answer is you have to evaluate somebody's experience.
Yeah.
That there won't be necessarily one piece of paper to tell you somebody's qualification, but looking at somebody's CV, seeing where they've worked, what they've done, and talking to them and saying like, oh, so you've worked in an ICU for 25 years. You've done all these, these procedures. You've seen these patients. It's not quite as easy as just like looking up a certification status. Yeah. But I mean, the data is there. You just have to solicit it.
I agree with you 100%. And I will tell you, and I've told others, I said, I say, hey, don't take it for granted that I'm going to be the person you want me to be. I may be the worst nurse practitioner with 23 years experience in this country. Right?
Somehow I doubt that.
I mean but that's very possible. And that could be a pretty low bar, right? And so I always feel like I am having to prove myself, but that's just kind of one of the things that I want people to think about. I definitely, it is something that I have struggled with throughout my career because, I don't want people to just assume that I know everything, because I absolutely don't know everything. As you guys know, the more I have been in healthcare and in critical care, the more I realize we don't really know what the hell we're doing. I mean, 15 years ago, if I didn't put my ARDS patient or sepsis patient on Oxypa, I was being called an idiot. If I wasn't putting patients on an oscillator, I wasn't giving the best care. But now we're not giving Oxypa anymore. We're not putting patients on the oscillator. And so,
though ironically, steroids were the right answer at the beginning of your career. They were the wrong answer, for some years in the middle, and now they're the right answer again.
That's right.
So, you wait long enough and these things come back around.
That's right.
Yeah. And so, there is so much for me to learn after all these years. I really tell people, please, just treat me like everybody else, because doctors and even new graduates, they have a lot that they can teach me as well. And I really lean on them, and, just thankful for everything they've done for me.
Medicine is humbling.
So Gary, as we sort of get towards the end of our talk here, I want to there are a couple hardball questions, I guess, that I wanted to introduce and see kind of how what your reaction is. The first one, I want to get back to this idea of education, and I've had some conversations with some of my colleagues who are nurse practitioners, and they have actually shared some concerns that they had with me in terms of the direction some of these newer programs are headed. You'd alluded to how back when you were going through school, there was virtually, if not literally, a requirement for bedside nursing time. Now there is not. And so actually these nurse practitioners, and I'm thinking about the ones that I worked with in the Neurosciences ICU, had raised concerns about the that requirement going away, or that expectation going away. And they also had raised concerns about newer schools that are opening up that from their perspective seem to be lowering their standards, making it kind of easier or faster for you to go through. And they were coming from the perspective of like, perhaps on the one hand, it's like job security. Everyone has that, like, I don't want to lose my job to this person, period. But I think more so they were coming from the perspective of like, this person is going to be taking care of patients like the ones I'm taking care of, and how on earth are they going to do a good job of it? If we've eroded or diluted their training experience. So, what are your thoughts on that? Is this like an overstated concern? Is this truly an emerging issue? How do you think we can, as a society, as a patient-centered community, respond to that?
Well, regarding the 2-year experience, as I mentioned, when I went through it, it was a mandatory requirement. I will tell you that, well, first off, I've always got the patient at the top of my list. So I'm never willing to sacrifice patient care for something else. One's educate, whether you get 2 years of clinical experience beforehand or not. But here's what I'm going to say. Not everybody going into NP school is in their early 20s and just recently completed nursing school. And maybe they don't have a family and they don't have kids, and they're in no rush from a life perspective of what they want to do. But that's not everybody. And there are a lot of people going into nursing as a second profession. Maybe they were in accounting, maybe they were a teacher, maybe they were, something else completely unrelated to nursing. And they decide they want to change their career and be a nurse. They have to go back, they have to get a bachelor's degree in nursing. And if they want to go on and be a nurse practitioner, then they have to get a couple more years of experience before they can even enter an NP program. And I will tell you honestly, one thing that I've always appreciated about the PA program is how they get such a wide diversity of students with various backgrounds. And you can go from being a mathematician to being an accountant, and in 2 years, you can be a physician assistant. And you can be an excellent healthcare provider in the ICU. You can be an excellent physician assistant. And nursing, it was always, well, you have to do these 2 extra years. And I just felt like that wasn't necessary. That I appreciate that the 2 years for myself was very helpful. I always knew I was going to go into acute care nurse practitioner. There was no doubt about that. But I could see where if I was not sure what kind of nurse practitioner I wanted to be, that those 2 years would have helped me do that. But I realized not everybody is like me or was like me when I went to school. And I think, again, patient outcomes are always most important to me. But I really don't have a problem with that requirement going away. Ultimately, you only get out of a program what you put into it. If you put 100% in, then you're going to get 100% out. And I think it's completely understandable that people do not want to put in that extra clinical time and want to go right on to NP school and to be a nurse practitioner.
Yeah, great points. I mean, I think a couple of thoughts come to mind. One is that, implicit in this conversation is this idea that like all doctors are somehow the same, and that's clearly not true, right? There's clearly
That's right.
substantial variation in the skill and quality among physicians as well. And you have to go into experience. This is why you call references. This is why you want to talk to people who have worked with somebody before when you're hiring them, because not everybody is the same skill level, and frankly, it's not just a matter of experience. There's other factors to consider. How motivated is this person? Sometimes people are extremely motivated and pick up skills really fast. I've worked with some amazing ICU nurses who I'm like shocked to learn that they've only been doing this for like a year or two. And I'm like, really? Like you're fantastic. I thought, I thought you were older. Like,
that's right. And who am I to say you're not ready to go to NP school or,
Yeah.
I do kind of want to acknowledge, maybe steer head on into this sort of turf war question. That is to say that there are many doctors who are actively worried that they are going to lose jobs to NPs who, as far as their employer, the hospital, may be concerned, provide exactly the same services. Some people are very, very alarmist about that. How do you respond to that, Gary?
Yeah. Well, I think that there's enough room in the sandbox for everybody to play. I think that data suggests that we continue to have an aging population that is continuing to grow, and these people are going to require critical care at some point. Additionally, there was a presentation at last year's SCCM conference where it was reported that 50% of acute care hospitals did not have intensivist coverage. Most of these were in underserved areas. However, there was also about 20% of metropolitan hospitals that also did not have intensivist coverage. So, additionally, Dr. Timothy Buckman, who's pretty well known in the critical care realm of things, he pointed out about 5 to 10 years ago in one of his presentations that the bottom line is that there's going to be a shortage of doctors who are available to provide critical care compared to the number of patients who will need critical care. So I just don't think this turf war between NPs and doctors is real. And honestly, I think it's a bad look for doctors who continue to push the narrative. I think the real threat to the physician workforce in critical care is not NPs, but rather technological advances such as tele-ICU and artificial intelligence. And by the way, these are going to threaten the nurse practitioner workforce as well. So nobody's going to be safe from this. We have to get beyond this. My personal opinion is we have to get beyond this turf war and realize that critical care physicians and NPs can improve patient outcomes when we're working with each other, not when we're working against each other. And this is the best for everyone involved. I will say that while it seems a threat or it is perceived as a threat, one thing that I try to have as a life lesson that I was taught by one of the founders of this comfort zone camp for kids who have lost a family member is that when something bad happens, something good happens. And so we always have to think about, in this case, if there's a threat to my job as I perceive it now, and that's obviously a bad thing, I need to think of something good that can come from this. And I think that if we stop focusing on, losing my job to an NP, then I think we're going to have a hard time moving forward and finding other avenues, because I just don't think it's NPs. I think it's, as I mentioned, ICU, tele-ICU, artificial intelligence. Those are the real threats to our practice, and we're gonna have to figure out a way how to work in tandem with that, so that we can continue providing excellent care and making a living.
This is undoubtedly going to get me some hate from listeners, but I'm just going to say that while I'm a big proponent of AI and I do a lot of work with AI, I don't think AI is going to take my job anytime soon. I just think, and this is the part that's going to get me some hate, Elon can't even get his cars to drive, like when you think about all of the interpersonal complexities and all of like the challenges that go into our day-to-day jobs, I just don't see AI taking that anytime soon. I'm also, I share your sentiment that there is enough room in the sandbox for everyone to play. Like, I think that, we absolutely need more critical care providers. There's a reason why our show is the podcast for everyone who cares for the critically ill, because we need lots of these people. And it doesn't matter so much what the letters are after your name. It matters much more like what you do, what you know how to do, and, how you take care of these people.
Yeah. The evidence shows that critical care patients get the best care when it's done by a multidisciplinary team.
Yeah.
And I think that we're all part of the team. We're all working towards one goal, and there's plenty of room for everybody to join in and help out. I have worked with some amazing doctors in my career. We've talked about this in the past. They don't feel threatened. I don't feel threatened. And, we're just out there crushing it.
So yeah, Gary, I think that's a great discussion. I'm glad we kind of like hit that head on. I think it's interesting, like just in the same sense, at least my perspective on this is just in the same sense that there's room in the sandbox for PAs, for NPs, for us as physicians, of course. You know, yes, in theory, telecritical care could reduce the number of job opportunities for me. Sure, in theory, AI could reduce the number of job opportunities for me if I'm approaching this in like a me-centric way. But the reality is I think there's also room in the sandbox for those entities as well. We had a great discussion with doctors Jidri and Benenati about telecritical care and how that can actually provide access to critical care services to places that simply don't have it. They might have an internist or a family medicine doc or something similar with boots on the ground, but they really benefit from that extra support. And so, yes, in theory, there's a way where that could reduce the raw number of jobs that are out there. I'm not sure that we're really seeing that, and in fact, like telecritical care, with respect to its place in the sandbox, can also open opportunities for you and I to work next to one another in this, hub to sort of provide critical care services to places that wouldn't otherwise have them. Similarly, I think with artificial intelligence, I agree with Nick. I don't see AI taking over my job, but I certainly could see it making us collectively more efficient. We're already seeing that, to be honest.
Right. And I don't disagree with you guys at all. I
Yeah.
think I do not think our job is going to be taken away by robots or artificial intelligence or whatever it may be.
Yeah.
I think it will change what we do. It will redefine and it will shape what we do. And I think
Yeah, I love that. Yeah.
having NPs in the sandbox, so to speak, just redefines what you do.
It does. I
And
agree. Yeah, I agree completely.
my attendings are, I would not give them up for anything. I mean, this, it's just NPs are not going to be replacing MDs in a critical care setting, but it may cause you to have to change what you're doing. And I don't know if that's something that people are willing to do or not. And, it's happening with all these professions, right? This is not just an NP and an MD thing. I mean, I don't hear MDs talking about PAs taking their jobs. I don't hear NPs beefing about PAs taking their jobs. We're all working together. We got shifts that aren't being covered. We got patients who aren't being cared for. Get me that PA.
Yeah, I love that. And I think, I'm sure Nick, I'm sure you have some points, but as I hear you, Gary, I think it's almost about like it's reframing the discussion. It's not
That's
about
right.
my job is going to get taken away from me.
That's right.
Rabble, rabble, rabble. I'm angry. It's more like, okay, we have a cadre of MDs, DOs, PAs, NPs. We've got access to telecritical care services. We've got artificial intelligence that's built into our EMR. How can we use that to make the world a better place? How can we use all of these resources to deliver better care? That's really, I think, the healthy and productive approach, rather than, man, I'm not going to get as big of a bonus this year because this dang NP is eating into my salary. And I worry that is actually the tone of discussion. I don't know, Nick, what are your thoughts on that?
No, I completely agree with what you both just said. And I think that's actually the perfect note to end this conversation on. Yeah. That this is critical care is a team sport and we're all in it together.
So, everyone, today we discussed a really important topic. We've talked about the expanding roles of nurse practitioners, of physician assistants in the intensive care unit amongst critically ill patients. I think we had a really great discussion. We really tried not to leave any stone unturned. I hope you guys enjoyed it. Of course, we look forward to the feedback. We'd love to hear your thoughts. If you have any feedback, if you have any thoughts to share, please do so. We got a lot of places where you can
direct
reach out
all
to
hate
us.
mail to cyrus@criticalcaretime.com.
Yes, thank you. Please do. Well, I'll also say, of course, is we're going to have, we've got show notes, we've got our infographics, all that good stuff on our website, and that is www.criticalcaretime.com. Go ahead, check it out. Make sure to subscribe to our mailing list, and like I said, leave comments.
Yep. And that brings us to the part of the show where we like to say thanks. First of all, thank you so much to Gary for joining us. It was great having you on the show.
Thank you very much. I appreciate it.
Gary exemplifies what we want all of our listeners to do, because he wrote us a comment and we said, why don't you come discuss it with us? So please keep them coming. We love your comments, reviews, your shout outs on social media. We do read them. If you haven't given us feedback, please do so. 5-star reviews, please on your favorite podcast app. That helps other people find the show. You could tweet or X at us at CritCareTime, or individually at Nick M. Mark or at Askins_Razor. We're also on Threads, Instagram, YouTube, all kinds of places.
We'd also like to take this opportunity to thank C-Star Medical. So they're our sponsor for season 2. We're very fortunate and grateful to have them on board helping us produce these great episodes. C-Star Medical, as you guys may know, is advancing the science of cell-directed extracorporeal therapy to restore the balance of the dysregulated immune system in acute kidney injury and sepsis. Please take a moment and check out their website, cstarmedical.com, to learn more.
And before we go, we also want to say thanks to the incredible members of our podcast team that make this show possible. Our production folks over at Podpaste, Kurt Belknap, who composed the theme music you're hearing over me right now. All couldn't do it without the village that it takes to make this show.
That's right. And finally, our disclaimers: the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. Gary, again, thank you so much for your time and for contributing to this discussion. We really appreciate it. With that, thanks for listening. I am once again Dr. Cyrus Askin.
And I'm Dr. Mark. See you all next time.